Hi, I'm Dr. Mike McInnes. I'm one of the chief educators at Doctors in Training, and I want to welcome you to this solid anatomy lecture on the blood supply of the pelvis. Now, I'll be back a little bit later for some clinical correlations and the end of session quiz, but for right now, I'm going to turn you over to our primary lecturer, Dr. John Phelan.
Most of the blood supply to the pelvis is provided by the internal iliac artery. The aorta bifurcates into the left and right common iliac arteries, which in turn bifurcate into the left and right external and internal iliac arteries. The external iliac travels along the pelvic brim, never entering the true pelvis, and passes inferior to the inguinal ligament to reach the thigh. One external iliac branch of note proximal to the inguinal ligament that you may recall from the solid anatomy lecture on the anterior abdominal wall is the inferior epigastric artery. It runs superiorly between the peritoneum and the rectus abdominis muscle, forming the lateral umbilical fold. The internal iliac artery crosses the pelvic brim and gives off numerous branches. The branching pattern of the internal iliac is highly variable. Its branches are named according to their ultimate destination, not according to where they arise. There are 11 named branches of the internal iliac in the male, and 12 named branches in the female, and there are occasionally unnamed muscular branches as well. Some of the branches have duplications or triplications or beyond. Often, an anterior division and a posterior division of the internal iliac may be distinguished. The posterior division generally gives rise to the iliolumbar, lateral sacral, and superior gluteal arteries, while the remaining arteries arise from the anterior division. The iliolumbar artery leaves the pelvis by crossing the posterior part of the pelvic brim to supply muscles in the posterior abdominal wall. Branches that cross the anterior surface of the sacrum and pass through the anterior sacral foramina to contribute to the blood supply of the spinal nerves, the cauda equina, and the spinal cord are the lateral sacral arteries. Branches of the lateral sacral arteries exit the posterior sacral foramina and supply muscle and skin immediately posterior to the sacrum. Recall that the median sacral artery is an unpaired artery that arises from the bifurcation of the aorta, often on the posterior side of this vessel, and descends into the pelvis along the midline of the sacrum. The lateral sacral and median sacral arteries anastomose on the anterior surface of the sacrum. The superior gluteal artery dives between roots of the sacral plexus, often between the lumbosacral trunk and S1, passes the superior edge of the piriformis muscle, and exits the greater sciatic foramen to reach the gluteal region. The inferior gluteal artery also dives between roots of the sacral plexus, often S2 and S3, passes the inferior edge of the piriformis, and exits the greater sciatic foramen to reach the gluteal region. The superior and inferior gluteal arteries supply muscles of the gluteal region. The internal pudendal artery does not dive between roots of the sacral plexus, but instead crosses the plexus anteriorly and dives between the piriformis and coccygeus muscles to pass through the greater sciatic foramen. It then follows the same course as the pudendal nerve, passing between the sacrotuberous and sacrospinous ligaments and entering the pudendal canal via the lesser sciatic foramen. It has the same distribution as the nerve, dividing into 3 main branches: the inferior rectal artery, the perineal artery, and the dorsal artery of the penis or clitoris. The middle rectal artery often, but not always, branches from the internal pudendal artery. Recall that the superior rectal artery is a branch of the inferior mesenteric artery, and, as was just mentioned, the inferior rectal artery branches from the internal pudendal artery in the pudendal canal. The three rectal arteries anastomose with each other. The obturator artery travels along the lateral wall of the pelvis with the obturator nerve and vein. The obturator neurovascular bundle passes through the obturator canal, a pathway through the obturator internus and externus muscles, and the obturator membrane between them. About 20% of obturator arteries arise not from the internal iliac, but rather the external iliac artery, often as a branch of the inferior epigastric artery. The umbilical arteries traverse the pelvis to reach the anterior abdominal wall and then turn superiormedially to reach the umbilicus, forming the medial umbilical fold on the underside of the abdominal wall. During fetal life, the umbilical arteries return blood from the fetus to the placenta via the umbilical cord. After birth, the umbilical cord is cut and the distal parts of the umbilical arteries collapse. The remaining obliterated portions of the umbilical arteries are named the medial umbilical ligaments. Occasionally, you will see the terms umbilical folds and umbilical ligaments used synonymously. But the anatomical distinction is that the umbilical folds are areas of parietal peritoneum elevated by underlying structures. For the inferior epigastric folds, the underlying structures are the inferior epigastric vessels. For the medial umbilical folds, it's the medial umbilical ligaments. And for the median umbilical fold, the structure underlying the peritoneum is the median umbilical ligament, which is the remnant of the urachus of the embryo. The proximal portions of the umbilical arteries remain patent in the adult, and several branches may arise from them. Very often, the umbilical arteries give off superior vesical arteries that supply the superior half of the urinary bladder. There are often multiple superior vesical arteries that may arise from the umbilical artery, or from another branch of the internal iliac, or directly from the internal iliac itself. Remember, the branching pattern of the internal iliac is highly variable. If you are asked to identify a superior vesical artery in the anatomy laboratory, don't be concerned with where the artery originates from. Simply look for an artery that plugs into the superior half of the urinary bladder. That advice holds true for any branch of the internal iliac. Name it according to where it terminates, not according to where it originates. Now that we've beaten that point to death, let's continue naming branches of the internal iliac artery. We've said that the superior half of the urinary bladder is supplied by superior vesical arteries, so how about the inferior half? In males, one or more inferior vesical arteries supply the inferior half of the bladder, as well as the nearby seminal vesicles, prostate gland, and occasionally the distal part of the vas deferens. It is generally accepted that females do not have inferior vesical arteries, though there are occasional arguments to the contrary. It is most often said that the inferior half of the female bladder is supplied by the vaginal artery. You've probably guessed from its name that the vaginal artery also supplies the vagina. The uterine artery approaches the lateral margin of the uterus by passing through the transverse cervical ligament, or cardinal ligament, which extends laterally from the inferior third of the uterus. The artery crosses superior to the ureter as the ureter approaches the base of the bladder. This relationship may be remembered by the phrase water under the bridge, where the water is the urine carried by the ureter and the bridge is the uterine artery crossing over it.
Welcome back. Now, we're almost finished, but I want to interrupt Dr. Phelan for just a second and discuss this concept of water under the bridge. Again, this is a phrase that helps us remember that the uterine artery crosses superior to the ureter. Now, this isn't going to be the last time you hear this phrase, so what's so important about this one tiny little anatomical fact? Well, when you're doing a hysterectomy, for instance, you're removing the uterus. And you have to identify the uterine artery and tie it off or ligate it, and then cut it. But because the ureter courses so close to the artery, the ureter is at risk for being accidentally clamped or ligated, and that would be a bad move. So remembering that water crosses under the bridge helps you correctly identify the uterine artery and then make sure that you're not going to ligate the ureter by mistake. Now, this is one clinical situation where knowing the anatomy is absolutely critical. So let's go through these study guide questions before moving on, just to make double sure that you know this. The first question says, does the ureter pass inferior to or superior to the uterine artery? Remember, it's water under the bridge, so the ureter passes inferior to the uterine artery. And then, where's the point at which the ureter crosses the uterine artery? It crosses about 2 centimeters superior to the ischial spine. All right, let's get back to Dr. Phelan in the lecture.
The uterine artery anastomoses with the vaginal artery inferiorly and then turns superiorly to run along the lateral margin of the uterus in the broad ligament, a peritoneal ligament extending laterally from the upper 2/3 of the uterus. The uterine artery sends a branch that runs along the uterine tubes and anastomoses with the ovarian artery distally. With regard to venous drainage of the pelvis, the branches of the internal iliac vein mostly mirror the branches of the artery and are named accordingly. The exception is that there is no umbilical vein draining into the internal iliac vein. During fetal life, the umbilical vein delivered oxygenated blood from the placenta to the fetus by draining into the inferior vena cava. At birth, the vein collapsed, leaving the ligamentum teres and the ligamentum venosum as its remnants in the adult. There is plenty of information about the pelvis left to learn. Download the next 2 solid anatomy lectures to find out about the perineum, the external genitalia, and the pelvic viscera.
Welcome back again. Before we move on to the end of session quiz, let's discuss another clinical condition, which is uterine fibroids. Now, I know we didn't discuss the uterus in much detail in this video, but I'm bringing it up because one of the treatment options for uterine fibroids has to do with the uterine blood supply. So first of all, what are fibroids? Well, fibroid tumors are benign tumors of the smooth muscle cells of the myometrium of the uterus. They can also be called leiomyomas. We describe them according to their location in the uterus. Are they submucosal? Are they intramural? Are they subserosal? Are they cervical leiomyomas? So lots of different terms. Now, fibroids are one of the many causes of pelvic pain, which is a common reason for women to present to the doctor. So fibroids can cause pelvic pain. They can cause heavy, prolonged, painful uterine bleeding, which is sometimes called dysfunctional uterine bleeding. They can cause some infertility sometimes. And then also they can cause some pain with intercourse, which is called dyspareunia. You might be able to palpate a large fibroid on a pelvic exam. And then once the fibroids are suspected clinically, the diagnosis can be confirmed with an ultrasound. Now, to treat fibroids, you have some different options. One option is to do a hysterectomy. You're going to remove the uterus. But that's big-time surgery, and obviously one of the results of hysterectomy is sterility. You also have to consider the cost, the pain, and recovery time. And this is not completely risk-free surgery. You could damage the pelvic floor, and that could cause problems with intercourse or even some urinary incontinence. Now, if you have a patient with fibroids who still wants to be able to have children, she wishes to avoid major surgery, there's a treatment option, a minimally invasive treatment option for fibroids called fibroid embolization. So using our knowledge of the blood supply to the uterus, it's possible to occlude the blood flow in the specific branches of the uterine arteries that supply the fibroids. Often there may only be one large fibroid that's causing the symptoms, and if we can treat that, there's no reason to surgically remove the entire uterus. So the embolization procedure is performed in the hospital under anesthesia, and you put a catheter, a long, thin plastic tube, into the femoral artery in the inner thigh, and you do this under fluoroscopy, under x-ray, and then you can inject some contrast into the vessel so you can actually see the outline of the blood vessels. And then you thread the catheter up to the aortic bifurcation, then down into the internal iliac artery, and then down into the uterine artery, because the uterine artery branches from the internal iliac artery, right? Well, once you're in the uterine artery, you inject the contrast and figure out which branch of the uterine artery is supplying the fibroid. Then you block you're going to block the flow of blood. So you're going to inject either some tiny particulate matter, or maybe you're going to inject some type of sclerosing agent, such as strong ethanol. That's going to actually injure the vessel, and it's going to cause it to scar down, and that vessel is going to close off. Or another type of embolization is where you inject a coil of wire to form the embolus. But however you do it, you're forming an embolus that blocks the blood supply to the fibroids, which causes the fibroid to shrink over the course of several weeks to months. Now, we don't usually recommend pregnancy after uterine artery embolization, but it is possible if desired. The main risk with this procedure is you might cut off blood flow to other organs at the same time. So Dr. Phelan discussed the uterine artery, the ovarian artery, the vaginal arteries, but in real life, the uterine artery anastomoses with the ovarian artery and also somewhat with the vaginal artery. So if you do an embolization that ends up occluding the blood supply to the ovary, the patient could be at risk for losing an ovary. So that covers the blood supply of the pelvis. Now I want you to pause the video, answer the end-of-session quiz questions, and we're going to go through those answers together. All right, let's get started. First question, what ligaments are formed by the obliterated umbilical arteries in the adult? That's the medial umbilical ligaments. Next, typically what artery supplies the inferior bladder in males and in females? So in males we call it the inferior vesicular artery. Now it's agreed upon that females don't have inferior vesicular arteries. Therefore the inferior bladder is supplied by the vaginal artery in women. Next, what artery passes through the transverse cervical ligament to reach the pelvis? It's the uterine artery. Next, which arteries supply the rectum, and from which arteries did these rectal arteries arise? So the superior rectal arteries arise from the inferior mesenteric artery. The middle rectal artery arises from the anterior division of the internal iliac artery. And the inferior rectal artery arises from the internal pudendal artery, which itself arises from the anterior division of the internal iliac artery as well. Next, what are the main branches of the anterior division of the internal iliac artery? So you have the obturator artery, the superior vesicular artery, the umbilical artery. In males you have that inferior vesicular artery and then the prostatic branches. And then in females you have the uterine artery and the vaginal artery. There's also the internal pudendal artery, the middle rectal artery, and the inferior gluteal artery. Next, which three arteries supply the pelvis but do not arise from the internal iliac artery? And which vessels supply these three arteries? So there's the superior rectal artery, which again is supplied by the inferior mesenteric artery. There's the ovarian artery, which is supplied by the aorta. And then there's the median sacral artery, which comes from the aortic bifurcation. Next, where's the iliac artery found in relation to the iliac vein? So the iliac artery is lateral and anterior to the vein. Next, which branch of the common iliac artery supplies the pelvic structures and which branch supplies the leg? So the internal iliac artery supplies the pelvic structures and the external iliac artery supplies the leg or the extremity. External iliac extremity, pretty easy. Next, what are the three branches of the posterior division of the internal iliac artery? So you have the iliolumbar artery, the lateral sacral artery, and the superior gluteal artery. And the last one, which artery and nerve pair exits inferior to the piriformis muscle? That's the inferior gluteal artery and nerve. Which artery and nerve pair exits superior to the piriformis? That's the superior gluteal artery and nerve. All right, the last thing we have for you is your mock practical with some images for you to label. So let's get some practice labeling these in a timed setting.